Information provided does not constitute legal or professional advice and should not be relied upon as such. Attendees are encouraged to consult with their employers or legal advisors for specific guidance tailored to their individual circumstances. The presenter, Natasha C. Miller, does not have any affiliations with any entities that could be perceived as a conflict of interest in relation to this presentation. The presenter shall not be responsible for any damages resulting from any error, inaccuracy, or omission contained in this product. Also, attendees will receive a copy of the slides after the event, and no part of this publication, seminar, or training may be reproduced or transmitted in any form or by any means, electronic or mechanical, including photocopy, recording, or any other form of information storage and retrieval system without written consent from the author and publisher, Natasha Miller. Requests for permission to reproduce contents should be submitted in letter of intent and directed to Natasha Miller by email to natasha@ncmhealthcare.com. So let's get started for what everyone has come today. Thank you so much for coming in. At the end of this presentation, you will have a deeper dive into the billing and coding procedures relevant to MDPCP practices. You'll be able to identify some common billing and coding guidelines specific to primary care services, as well as be able to apply coding principles to accurately document and bill for services provided within MDPCP practices. And so our agenda for today, I do have a lot of information to cover. So hopefully this will be really great information for you. I'm going to first start with some strategies to help in improving accuracy and efficiency in your billing and coding. Put in the chat, let me know. I would like to know if you are a biller or coder. Let me know what is it that you do on the non-clinical side. I would like to get to know you a little bit more. We're also going to deep dive into some medical necessity. I'm going to discuss some common coding codes in primary care, and then I will dive into duplicate denial management and then have some recommendations. So as I am going through today, feel free, you can put your questions in the chat. We'll answer them at the end. And then let me know if you are in the industry and you're working as a biller or coder, or what is it that you do on the non-clinical side? I would like to know, or even if you are on the clinical side, let me know as well. So let's get started. So some strategies for improving accuracy and efficiency. Of course, technology is at the forefront, right? Hopefully you are using and leveraging some coding and billing software to enhance that accuracy. We do have EHRs in place, but then also within the EHRs, we are using our practice management systems, right? And so having your practice management system to help you with leveraging your billing and coding is going to be very helpful. As well as you want to continue your education. So importance of ongoing training and professional development. You have to stay current with our current changes, our industry changes. There's so much that is changing. And so if you are, what you're doing today, coming to these seminars, attending any conferences, workshops, please continue to do that because we are constantly changing and evolving in this industry, as well as quality assurance. And I'm going to give some recommendations towards the end of this presentation and how you can have and implement some internal audits and quality checks and utilizing that feedback for any error and analysts to improve in those processes. So important. Some common challenges and solutions right off the bat. So you want to begin to identify and address any common coding errors, manage any denies and rejected claims, right? Have a system in place for that. And I'm going to give you some tips and tools on how to do that and be able to handle any complex cases and unusual coding scenarios. Best practices would be to have some best practices in place, some policies and procedures in place on how to reduce those claim denials and who's working them. What does the follow-up look like for those? Have effective communication with the insurance companies and healthcare providers. That's so important. You don't want to just let your claims stay stuck in the denial or the rejected phase, right? So you got to follow up, communicate, be able to resolve the issue. And hopefully, if you're able to send out clean claims up front, that's great. But if not, have those best practices in place on how to be able to work those denials. So I see in the chat, I have business admin, experience in billing and revenue cycle. I love it. And then a coder here, do quality measure for coding, adult medicine and pediatrics. Excellent. Thank you so much for sharing. Also, you want to be able to leverage data analytics. So this is so important. Your data is going to tell you and let you know what are the trends, what are the errors, right? Where can we improve? Especially if you're doing quality measures, if you're looking and doing any type of audits, and even if you're not doing audits, the data will also let you know what do we have for the top denials? Who maybe is the provider that's repeatedly, maybe possibly using incorrect codes, or maybe even the billers and coders using incorrect codes and modifiers. So that data is so important. And then having the tools and techniques to be able to utilize the data is going to be helpful as well. Continuing with some strategies, you want to also be able to engage with your patients, have that patient education and engagement. This is so important. If you can have tips available for your patients and help educate them on their bills and insurance, and also if you can do this before they actually receive the bill, it's going to be helpful. So the patient is not caught off guard, because there's nothing like a patient receiving a bill unexpectedly, or they didn't know possibly something was not covered, or they have to pay more than they expected, right? So you want to be able to educate the patient beforehand and have that engagement strategies there. Have your patients involved. This will be able to help reduce those errors and disputes. And hopefully you have some type of claim scrubber in place. This will also help in any type of errors that may come across. So claim scrubber is very beneficial before the claim goes out. So your claim scrubber can help look for error detections and can identify maybe if a code is missing, or maybe if a code is not sequenced correctly, for example. Have edit rules in place. Within claim scrubbers, you can have the scrubbers to where you're using the system, or you can make it to where it fits your organization. This will also help prevent those denials and reduce those denials and increase timely filing, because it's nothing like submitting a claim and then it doesn't get submitted timely, and then you're losing out on revenue just for that as well. So having a claim scrubber in place will be so helpful. So excellent. I see we have in the chat, we have a quality and compliance officer, excellent, a RCM director for FQHC, and a quality coordinator. I love it. Thank you so much. Yes, excellent. So let's dive into medical necessity. Now, medical necessity is so important, especially anyone that's looking at documentation. If you are reviewing documentation, you're probably reviewing to see, was the information documented that the provider wasn't medically necessary for what was done, right? And then also when the claim goes out, the insurance company is looking to see, was it medically necessary? So the documentation, there must be documentation. If there is no documentation, it was not done, right? And so that's number one. Documentation must support that medical necessity. And also the documentation must support the diagnosis. It's so important. And so if you are reviewing documentation, you want to be making sure that the provider has that medical necessity in that documentation. Because what happens if the documentation is not complete, it will result into an incomplete record. It can be a missing record, which can result into fraud, as well as patient safety, right? And then this is lack medical necessity decreases in the patient safety. So it's so important that the provider is documenting and that there is medical necessity. So I want to make sure that everyone is hearing me okay. I think in the chat, someone says they're having audio issues, but please let me know if there are any issues. Now, there are federal rules and payment policies that you want to be mindful of. Of course, we have confidentiality and HIPAA, and HIPAA came into place in 1996. Now, HIPAA was here to make things standardized, because before HIPAA, it was not standard, right? And so making sure that charges went out standardized. This means that the employee's information also is being disclosed properly, and not just anyone is looking at information. Those that need to know is looking at that information. And then we have the Federal False Claims Act. So when we're looking at the Federal False Claims Act, we're looking at two things. Do you knowingly see any federal false claims or payments, right? Or is there a use or cause made as a false record or statement? And so if you are diving into the claims, you want to be mindful of this act because you do not want to be sending out any false claims, and just reminding your providers and making sure the documentation is there, the correct codes are being used, right? We are not unbundling, we're not putting codes down if they're not doing that service is so important. And then also you want to be mindful of the Fair Debit Collection Practices Act. And this goes for individuals that are collecting and making sure that you are fair in the collecting in any of those medical billing services, and that you are not harassing patients, right, or threatening patients for that collection. Now, let's dive into some common coding codes in primary care. And before we do that, I want to talk a little bit about upcoding, as well as talk about some common coding issues, and then we'll dive into some of those codes. Now, upcoding is reporting higher codes without the support of that medical necessity, medical facts, or provider's documentation. And so this is something that we should not be doing. If you are working with your providers, right, you are letting them know the coding guidelines, you're letting them know how to properly code for their services. Undercoding or downcoding is reporting lower codes, maybe to avoid an audit. And this is something that we also should not be doing. It is not safe for the patient to downcode, and this is also a compliance risk. And so you want to make sure. I work with providers on a daily basis and review their charts, and sometimes providers think that, oh, okay, it's okay that I downcoded compared to not upcoding. But no, we want to make sure that they're in compliance across the board, right? And that they have a good, clear understanding how to document the services that have been provided, if it's an office visit, if it's a procedure, whatever that service, and it needs to be medical necessary as well. Now, when we're looking at some common coding issues across the board, we have, of course, unbundling, incorrect usage of modifiers, duplicate billing is very high, I see across the board. Upcoding as well, using unspecified diagnoses, and I see this a lot. A lot of providers do not know which specific code to use, and some claims can be denied if they're not using more of a specific diagnosis. So if you are working with your providers with the diagnosis codes, hopefully you can help train them and provide them more specific codes in the specialty that they are in. Documentation errors, incorrect usage of procedure codes, improper charge entry, and then overall the lack of guidance knowledge. And so it's very important that we help educate our providers, pull your data, pull your report. What are the top 5 or the top 10 denied claims? What are the top 5 or top 10 errors that you're seeing across the board? This will be a guidance for you to help educate your providers to say, okay, this is what we see coming across. Pull the reports, pull the records, review, and educate your providers on how to properly document, how to properly code, and how to properly use the codes, especially when it comes to the unbundling. A lot of times the providers just don't understand that there are some codes that are bundled into one. If providers are doing any procedures in office, or maybe if any of your providers are doing procedures out of the office, okay? So important. Now I'm going to dive into evaluation and management, because I just want to do a quick overview. These codes are heavily used across primary care and across all specialties. And so I just felt it's really important to just do a quick dive into this, and then we'll go into some additional codes. So new versus established. So it's very important to understand what's the difference from a new patient and an established patient. So just briefly reviewing these guidelines, solely for the purposes of distinguishing between new and established patients. Professional services are those face-to-face services rendered by physicians and other qualified healthcare professionals who may report evaluation and management services. A new patient is one who has not received any professional services from the physician or other qualified healthcare professional, or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. So that's a new patient. Now, an established patient is one who has received professional services from the physician or other qualified healthcare professional or another physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. So just reviewing new versus established. Now, when we look at these codes, we have our new patient office visit codes 99202. It starts with 99201 has been deleted. And so we know now that your providers can code based off of medical decision-making or time, right? And so if it's medical decision-making for 99202, it's straightforward. 99203 is a low medical decision-making. 99204 is a moderate, and 99205 is high. Now, if the provider is coding based off of time, for 99202, 15 minutes must meet or exceed. And it's very important that your provider documents in their record how much time they spent if they're using time. 30 minutes for 99203 must meet or exceed. 99204, 45 minutes must meet or exceed. And a 99205, 60 minutes must meet or exceed. Now, when we look at our established patient codes, we have a 99211. Medical decision-making or time does not equate. Nothing is in that code. But when we get to 99212, this is where we have a straightforward medical decision-making, or if they're using time, 10 minutes must meet or exceed. 99213, it's low medical decision-making, or 20 minutes must meet or exceed. 99214, we have a moderate, or 30 minutes must be met or exceeded. And then 99215, high medical decision-making, or for 40 minutes must be met or exceeded. So you'll notice that the differences in the time is not the same compared to a new patient and an established patient. So important. And providers, they need to document how much time was spent with the patient. Okay, so let's do a quick knowledge check. So we have a patient visits Dr. Johnson, a primary care provider, for a routine checkup. 2 years ago, the patient saw Dr. Lee, who is also a primary care provider and part of the same group practice as Dr. Johnson. So how should this patient be classified? Will it be A, new, B, established, C, consult, or D, observation? Put your answer in the chat. I'll give you a few seconds. Put your answer in the chat. Excellent. I see answers coming in. Thank you so much for participating. Yes, excellent. Put your answers in the chat. Okay, let's go over this together. So yes, it will be B. Great job. Established patient. Correct. The patient is not new because they have received that professional service from the physician of the same specialty and subspecialty in the same group within the past 3 years, right? So important. Excellent. Okay, now let's dive into transitional care management, TCM guidelines. So we have our codes 99495 and 99496. Now, these codes are used to report transitional care management services. These services are for newer established patients whose medical and or psychosocial problems require a moderate or high level of medical decision-making during transitions in care from an inpatient hospital setting. So this includes acute hospital, rehabilitation hospital, long-term care, and acute hospital, partial hospital, observation status in a hospital or skilled nursing facility, to the patient's community service. And examples can be the patient is transitioning to a home, rest home, or assisted living. Home may be defined as a private residence, temporary lodging, or short-term accommodations, for example, hotel or campground or ship cruise, for example. So when we look at these codes, we look at the code 99495. We have transitional care management services with the following required elements. So communication. There needs to be communication, direct contact, telephone or electronic, with the patient and or caregiver within 2 business days of discharge. Also, it's important that this is documented in the patient's medical record, and at least moderate medical decision-making during the service period face-to-face within 14 days of that calendar discharge. So You have to have within 2 business days, maybe the provider calls or there's some type of email contact, hopefully a telephone or some type of contact with the patient. And then within 14 days, there is a visit that is face-to-face within 14 days of that discharge. And the medical decision-making needs to be moderate in order to use the 99495. Now, the 99496, same thing needs to happen within 2 days. There needs to be some type of contact, and this needs to be documented in the patient's record. The medical decision-making, however, needs to be a high level of medical decision-making, and there's face-to-face contact within 7 calendar days of that discharge. So that's the difference. So either you're using the 99495 or the 99496. And here on this slide, I have a table for you to be able to see it. So if it's within 7 business days and it's moderate, 99495. If it's within 8 to 14 days and it's moderate, it will still be a 99495. If it's within 7 business days and it's high, 99495. If it's within 8 to 14 days and it's high, excuse me, I said 99495, but this is a 99496 for high. And then it's 99495 if it's within 8 to 14 days. So they're only going to get the high if it's within the 7 days for the 99496. Everything else would be a 99495. Okay. Also, it's very important to make sure that you're documenting in the EHR either what type of communication was done. That's so important. That has to be done in order to use this code as well. And so now let's talk about advanced care planning. Now, advanced care planning codes, we're using the codes 99497 as well as 99498. And these are used to report the face-to-face service between a physician or other qualified health care professional and a patient, family member, or surrogate in counseling and discussing advance directives with or without completing relevant legal forms. Now, advance directive is a document appointing an agent and or recording the wishes of a patient pertaining to his or her medical treatment at future time. And this should he or she lack decisional capacity at that time. So examples of written advances of directives can include, but are not limited to, a healthcare proxy, a durable power of attorney for healthcare, a living will, and a medical orders for life-sustaining treatment. And so this is just some examples, but not limited to. Now let's look at the codes pertaining to advanced care planning codes. We have the 99497. And so the 99497 is for the first 30 minutes face-to-face with the patient, family or family members, and or surrogate. The 99498 is the add-on code for each additional 30 minutes. So you cannot use the 99498 without the 99497. And it's for each 30 minutes. So you want to make sure you have an additional 30 minutes that you're using this code for. So just to briefly summarize it, advanced care planning codes can be billed with another visit on the same date of service. The first 30 minutes is the 99497. Each additional second 30 minutes is 99498. You want to append a modifier 33 when you're using advanced care planning on the same day as an annual wellness visit to waive the co-insurance. So that's so important as well. Making sure you're using the proper modifiers as well. So thank you so much. Put your questions in the chat and we will go over the questions at the end. I know that the hostess are going to be collecting the questions. So let's look at the HCPCS codes. Few HCPCS codes that I want to go over. So we have our initial preventative physical exam. So this is the G0402. Now this code represents the face-to-face visit for initial preventative physical examination for a new Medicare beneficiary. Now this service is on a one-time visit for the new beneficiaries within the first 12 months of Medicare enrollment. Right? It's so important that this is within the first 12 months. Now, when we look at the G0438 and 439, so our G0438, this code is used when the provider performs a patient's first annual visit, also known as the AWV, as part of the annual wellness program. Now, at this visit, the provider takes the patient's medical history, assesses the risk factors, and provides a personalized prevention of planned service. Now, the G0439 is that annual wellness visit, but for the subsequent visits, right? So you use this code for those subsequent visits and not for the first annual visit. And then we also have the G0468. Now, our G0468 is for the federally qualified healthcare visits, for the IPPEs, or the annual wellness visits. And this is, again, for those FQCH visits that includes the initial preventative physical examination or annual visit, and includes a typical bundle of Medicare covered services that will be furnished per diem to a patient receiving that IPP or AWV visit. So I'm going to talk to you about some duplicate denial managements, because this is something that I see across the board working with providers and also billers and coders, duplicates, and how to work these and what you should be looking for. Now, I have some steps provided to you. And just a reminder, you will receive these slides at the end of this event. And so you'll have access to all of this information. So step number one, first, you want to review the claim, right? Carefully examine the claim to ensure that it is indeed an exact duplicate from the previous submitted claim. Look for any discrepancies or errors that may have caused this to flag as an actual duplicate. After you do that, you want to verify the original claim. So you need to retrieve that original claim. That needs to be referenced as a duplicate. Compare any details from the original one to the one that you're looking at to see, well, what are some differences? What are some similarities? Then from there, you're going to determine the reason for the duplication. So identify, why is this claim actually a duplicate? It could be a system error, or it may not be. It could just be also a human error. So understand and look to see, is this really a true duplicate? What happened? Why did it happen? You have to understand the root cause. This is going to help prevent any future occurrences, right? Because if it's a human error, maybe the biller or coder needs some training on how to properly get the code submitted out so it doesn't show as a duplicate, right? Correct any errors, right? So you got to make sure you're correcting the errors. Just don't go back and submit the claim, because then it's going to show as another duplicate. You have to go in and make the necessary corrections, ensure that all information is accurate and up to date before resubmitting that claim. Provide any additional documentation if that is what is needed as well. So if you need to gather that documentation and submit that as an attachment to send out, please do that, so that can support to show, okay, this is actually not a duplicate. And then you want to be able to resubmit the claim. Now, once all those necessary steps have taken to address the duplicate, resubmit the processing, ensure that it has been submitted to the appropriate channels, right? Don't just let it sit there. From there, you have to monitor the claim status. So keep track of your claim denials. And I know some organizations maybe are doing this manually using a spreadsheet, or you have some type of system in place, but you need to keep track. Don't let it just go out and there's no way to see what actually happens. Keep track of your claims after you have come back and resubmitted to make sure it properly gets paid. Because a lot of times, if it's not necessarily a duplicate, it could have been missing a modifier, right? Is it missing the appropriate modifier to show this is actually not a duplicate? Or it could have been a true duplicate. So you need to find out what it was, correct it, and resubmit it, and then monitor the claim status. This will be helpful in working, because you want to decrease those duplicate denials and identify the root cause. And then also, if it's internally maybe a human error, provide some proper training and education to help reduce that as well. Now let's look at another quick knowledge check. Which of the following steps is not part of the process to address Code 18 duplicate claim? And so I'll read them for you. You can put your answer in the chat as I'm reading them. So is it A, review the claim to ensure it is indeed an exact duplicate of a previous submitted claim or service? B, provide additional documentation without correcting any errors found in the duplicate claim? C, verify the original claim and compare the details with the current one to identify differences or similarities? Or is it D, resubmit the claim after making necessary corrections and ensuring all information is accurate and up to date. So which of the following steps is not part of the process? A, B, C, or D? Put your answer in the chat. Thank you so much. I see your answers coming in. Excellent. Thank you. I'll give a few more seconds just in case anyone is still reading those answer choices. Okay, let's go over it together. Yes, your answer is correct. It is B. So provide additional documentation without correcting any errors found in the duplicate claim, right? And so you want to make sure that you go through those steps, correct the claims before you're just providing any documentation. That's so important. Because if not, it could come back as another duplicate, and we don't want that to happen. So if you have questions, please put them in the chat because I will be addressing them once we get to the end. And I know our time is almost coming up. We have about 10 minutes, I believe so. And so I'm now going to dive into some recommendations. So some recommendations on just having your strategies in place and how to improve your accuracy in your billing and coding. So audit policies and procedures, you want to have this in place. If you do not, I highly recommend, and I'm going to dive through these steps and what it looks like. You want to audit quarterly. This is so important. And if you can set your goals to 98% or higher for those audits, that would be great. And then you want to have some training programs in place. So what does this look like? Implement some audit policies and procedures. And so the audit policies is to establish to make sure the integrity of the claims that are being processed are following the federal, state, and local levels. This is so important, right? Have those policies in place. And then the procedures and statements to identify, well, what are the actual audits? What will they address? Why are we actually doing the audits? Who is going to perform the audits? And then also, how often will the audits take place? You want to have that information in your policies and procedures. So important. As you do that, then you're creating your audit plan. And now your audit plan, this is where it dives in deeper. What will your audit actually look like, right? So your audits they can start off monthly, or they can start off, quarterly or for a 6 months transition, however it will work for your organization. But if you have not done any audits, I would highly recommend a baseline audit, start off monthly and then transition from there. Who will be audited in the audit plan? You have your physicians, they need to be audited, physician assistants, nurse practitioners, your medical billers, coders, they also need to be audited. And then you also need to have compliance audits. So important. Keeping your audit plan simple, and then you can expand it if need be, right? So maybe you're not starting off with all of these components. You can keep it simple and then expand. But if you're not auditing anyone, it needs to be at least your providers, your physicians, assistants, nurse practitioners. They need to be audited to making sure they're properly documenting, properly coding, right? There's no fraud happening, no abuse taking place. That's so important. Your baseline audits, what will this look like? So you can have 20 charts for your physicians, physician assistants, nurse practitioners, random sample audit records for each providers. I would highly recommend, if you have not audited any of them before, maybe grab the last 3 months and do random samples of those providers. You can have maybe internal auditors provide this, or if you need to outsource this, this is also an option for you. Again, the goal should be 98% or higher. The compliance officer, if you have a compliance officer and office manager, they can pull the cases, or the auditors are able to pull the cases. It's totally up to your organization, but you want to make sure you have some type of system in place. It's great if the auditors have a work queue that they're able to audit out of or from. If not, they can, manually be able to do that. It just depends on the organization. You can use electronic system or a spreadsheet. I've seen it across the board, but you want to have something in place to be able to see what is happening. And the same thing with your billers and coders, right? There needs to be audits taking place. Audits taking place on if the coders are coding, or if they are sending out claims, and also for the billers. How do you know what type of education to provide to your coders and billers, to your team, if you're not auditing and what they're also sending out as well. Have in place, if you can, that 98% or higher. You're looking at what CPT codes, HIPAA codes, ICD-10 codes have been used, right? When you're reviewing your auditors, your billers and coders, pull the remittances, pull the claims, look to see what modifiers were used. Were they used appropriately? A lot of times the providers will not put the modifiers on their charges. It's the billers or coders that are doing that, right? And so that's where you can identify who needs the education and what type of education needs to be provided. Provide audit findings and summaries to be able to have as a record and provide that feedback to your providers and to the non-clinical staff as well. And again, your compliance officers or office managers can pull these cases or these charts, these encounters, and they can work, if they're auditors, they can work from home, have work queues to work out of, and they can track these electronically as well. All right, our last knowledge check number 3. Why is it important to have an audit policy in place for billers, coders, and providers? I'll read the answers and you can put your answers in the chat. So A, to ensure compliance with regulations, promote accurate and ethical billing practices, and reduce the risk of legal issues. B, to increase the workload and stress levels of the staff. C, to create unnecessary bureaucracy and hinder efficiency. Or D, to limit the access of billers, coders, providers to patient records. Yes, excellent. Thank you so much for putting your answer in. It is A, to ensure compliance with regulations, promote accurate and ethical billing practices, and reduce the risk of legal issues. It's so important that we are in compliance. What you don't want to have is your outside insurance companies come in and audit your providers and find that there is some fraud or abuse taking place. This can be prevented if you have some internal audits in place, you have education and training there for your providers. And now I'm going to dive into what the audit training and education can look like if you do not have this in place, and maybe you have it and you need some additional strategies on what to do. So of course you can have one-on-one training options available depending on your size of organization to your providers. Group training is also efficient. And so this is where you can have those lunch and learns for your providers, maybe online modules or discussion boards. Also, you can have, again, those online modules and discussion boards, and then test your self-knowledges at the end of each training modules to see, okay, does the provider or your coders and billers, are they understanding what has been provided? It's also important to provide real life scenarios if possible. So you can grab encounters and redact out PHI. Grab those encounters that you see on a day-to-day basis for your providers and be able to provide that information to those that you are presenting the training to. A sample auditing training plan. And so in creating your training plan, determining how you're going to audit, you can decide, okay, what's a level 1 or 2 or 3? Of course, to me, a level 1 is the providers. They are the ones that are providing the service, seeing the patient. So you want to make sure you are auditing the providers. And then you can go into your billers and coders, right? Audit topics can be, what are some high compliance risks? Maybe look at what is the OIG focusing on? What is your state or federal levels also focusing on? Coding guidelines, sequencing is also a priority. And then of course, documentation is also very important. Your training plan. So your training plan, schedule, and duration. What will that look like? If you are providing education and training, this can be a monthly session, quarterly, or yearly. Yearly can be when you have those yearly updates. So, right, you have CPT yearly updates or ICD-10 CM yearly updates. But monthly, you should possibly or quarterly be meeting with your providers, refreshing them, identifying any risks and refreshing them on the proper coding guidelines. If you have the capacity to have some type of weekly emails or maybe a newsletter, maybe a coding article where you're providing those additional educational resources, that's great. Monthly case scenarios. This can be provided in those staff meetings where maybe there's a trend of something and you want to bring to the attention to the staff. And then also have a monthly question and answer web conference chat that could be open to the entire workforce. That will be great as well. it again in your training plan, having that continual education. Yearly annual training will be provided to all individuals if they're passing their audits, right? So you want to determine how do you often you want to audit someone once you realize, okay, they're great at what they're doing. You may want to move them to a yearly part of it, or maybe they need to be monthly or quarterly until they get up to par, right? And then have the training documentation. Your training documentation should be kept electronically somewhere within your system for the workforce. So that way everyone knows, the compliance officer or whoever's keeping track knows who has been trained, and they can reference it if need be. And then, of course, you have feedback. You want to always ask for feedback. If you're providing any training or education, that's so important. It can be open-ended questions or questions that are the length and so forth. And then, as well as, again, I mentioned an online quiz can be given to your providers, billers, and coders, and helping them advance in billing and coding. And so, hopefully, this was helpful. I know it was a lot of information. Questions? Any questions that I can answer? And I believe some questions came through the chat. Yes.
Yeah, I actually have copied them all down if you want me to read them out to you. And I will just say we are at time, but we do have a break right now. So if everyone wants to stay on and hear these answers, or it's also recorded, so you can just catch the answers in the recording. So the first, not really a question, but a comment. Someone said, one of our main issues is providers incorrectly documenting an E/M code the same day as TCM services.
Okay. Oh, yes. So they can't, right. So there sounds like they're documenting an evaluation and management code and a transitional care management code. And so, yes, it has to be one or the other. And so that's the education that needs to be provided back. If the documentation is there that the patient was in the hospital and they are being seen for that TCM, then it needs to be documented for the TCM. And then possibly a corrected claim needs to be go out for just that TCM code.
Thank you. So we have another question. And I believe this was in reference to TCM codes. They asked, when you say electronic, could this be a message on an EMR or portal? Does the patient need to acknowledge the message?
Great question. Yes, there needs to be some type of contact with the patient. Yes. And so that's why it's very important that it's documented in the patient's record. So if there is no contact, then that needs to be documented as well. Because sometimes that can happen where possibly you weren't able to get in contact with the patient, but there was possibly an email that was sent out. That needs to be documented as well. Yes.
And then we have one more, and this is for the modifier 33. They asked, does the 33 go on the AWV code or the ACP?
On the ACP, the Advanced Care Plan code. Yes. Mm-hmm.
And it looks like we just had one more question pop into the chat. Can a TCM CPT be billed if a patient had a planned procedure? For example, they were admitted and discharged for a hip replacement. Then would they be eligible for TCM services?
So they were admitted and discharged for a hip replacement. So yes, if they were admitted in the hospital, now, yeah, because it wasn't just an outpatient procedure. So yes, if they were admitted in the hospital, a TCM can be billed. I have actually seen that as well. And so just making sure that that documentation is showing that. A lot of times what happens is the providers will forget to document when the patient was discharged. It's important to in the documentation they put in there when the patient was discharged from the hospital and that this is a TCM visit. That's so important as well.
I think that's all the questions we have. Thank you so much, Natasha.
You're welcome. Thank you.
If anyone has more questions, feel free to send them to our team and we will forward them to Natasha.